بسم الله الرحمن الرحيم. قال رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقه قولي. I would like to express my deep appreciation and special thanks for Dr. Zaki Taha Saleh, Professor of Anesthesia, Intensive Care and Pain Management, Faculty of Medicine, Zagazig University, Dr. Ikram Fawzi Sayyuh, Professor of Anesthesia, Intensive Care and Pain Management, Faculty of Medicine, Zagazig University, and Dr. Ali Muhammad Ali Barakat, Assistant Professor of Anesthesia, Intensive Care and Pain Management, Faculty of Medicine, Zagazig University, for their continuous encouragement and unlimited support. I would like also to thank my discussion committee, Dr. Hala Abdel Al-Attar, Professor of Anesthesia, Intensive Care and Pain Management, Faculty of Medicine, Zagazig University, and Dr. Ola Taha Abdel Daim, Professor of Anesthesia, Intensive Care and Pain Management, Faculty of Medicine, Mansoura University, for accepting to discuss this work. Finally, this work is dedicated to my lovely family, friends, and anesthetic personnel for their cooperation. Pericapsular nerve group block versus fascia block for pre and post-operative analgesia for elderly patients with hip fracture. By Khalid Mustafa Magdi Nasr Muhammad, Assistant Lecturer of Anesthesia, Intensive Care and Pain Management, Faculty of Medicine, Zagazig University. Introduction. Hip fracture is a common and extremely painful injury that predominantly affects the elderly population and usually requires surgical repair. The high incidence in older age groups is associated with multiple comorbidities which significantly influence anesthetic management. For this reason, regional anesthesia is often preferred over general anesthesia in hip fracture surgery and has been shown to be associated with a lower adjusted risk of mortality. Despite its disadvantages, regional anesthesia, despite its advantages, regional anesthesia, particularly spinal anesthesia, poses challenges in patients with hip fractures because positioning these patients is often very painful, as even minimal movement or overriding of fracture ends can cause severe discomfort. This frequently necessitates additional opioid analgesia or sedation, which may increase the risk of adverse effects in geriatric patients. Although opioids are commonly used for orthopedic pain control, their use in elderly patients is associated with significant complications, for example, delirium, respiratory depression, and prolonged hospitalization. Fentanyl is often considered the most suitable opioid because of its high potency, rapid onset, short duration, and minimal respiratory depression. Nevertheless, regional nerve blocks offer superior site-specific analgesia compared with systemic opioids with lower rates of complications. However, regional analgesia for hip fracture can be initiated early, even in the emergency department, to facilitate examination, transport, and imaging. Several peripheral nerve block techniques can be performed in the supine position, including femoral nerve block, 3-in-1 block, and fascia iliaca block. The ultrasound-guided fascia iliaca block is widely used to block the femoral obturator and lateral femoral cutaneous nerve. More recently, the pericapsular nerve group block has emerged as an effective technique that targets the articular branches of the femoral obturator and accessory obturator nerves, so it can provide analgesia with minimal motor blockade compared to the traditional femoral or lumbar plexus blocks. Aim of the reduction of pain in the pre- and post-operative periods in elderly patients with hip fracture by comparing pericapsular nerve group block with fascia iliaca block. Outcomes of the study. Primary outcome: analgesic effect of pericapsular nerve group block and fascia iliaca block using VAS score during patient positioning for spinal anesthesia. Secondary outcomes: quality of spinal anesthesia procedure, including duration of spinal anesthesia procedure, anesthesiologist and patient satisfaction, postoperative analgesia in terms of visual analog scale pain score, time to first rescue analgesia, and total postoperative analgesic consumption within the first 24 hours. Heart rate and mean arterial blood pressure during the same periods of VAS assessment. Complications related to the block technique and side effects of the used drugs. Patients and type of the study. This study is a prospective randomized single-blinded controlled clinical trial. Study site. This study was carried out at Anesthesia Intensive Care and Pain Management Department, Zagazig University Hospitals after approval of the Institution Review Board. Duration of the study 2 years from 2022 to 2024. Inclusion criteria. Patient acceptance, sex both sexes, age above 65 years old, body mass index from 18 to 30 kilogram per square meter, as a physical status 2 and 3, patients with unilateral hip fracture scheduled for surgical fixation under spinal anesthesia, expected duration of surgery less or equal to 2 hours. Exclusion criteria, associated trauma or multiple fractures, contraindication to spinal anesthesia like peripheral neuropathy, coagulopathy, or infection at the site of injection, allergy to the study drugs, impaired cognitive function or dementia, patients receiving analgesia for chronic pain, history of previous femoral bypass surgery, patients with inguinal hernia on the same side of the hip from withdrawal criteria. Patients have the right to withdraw from this study at any time without any negative consequences on their medical or surgical treatment plan. Sample size was 51 patients calculated by OpenAB software based on a pilot study, 17 patients per each group. Preoperative assessment. All patients underwent through preoperative evaluation, including history, physical examination, and routine laboratory investigations. Patients were kept fasting for at least 6 hours prior to surgery. Pain assessment tool was explained using a 10 centimeter visual analog scale ranging from 0 no pain to 10 worst pain imaginable. Explanation of the whole procedure to the patient was done and a written informed consent was obtained. Intraoperative. Upon arrival to the operating room, standard monitoring were attached to all patients, including ECG, non-invasive blood pressure, and pulse oximetry for continuous monitoring to heart rate, mean arterial pressure, and pulse oximetry. Fluid preloading. Lactated ringer in a dose of 6 milliliters per kilogram over 30 minutes was administered. Full resuscitation equipments and emergency drugs were prepared in advance. Before any analgesic intervention, each patient was asked for his or her pain intensity by visual analog pain score at rest, static VAS, and at movement, dynamic VAS, using 15-degree passive straight leg raising test. And the scores were recorded as a baseline. Baseline heart rate and mean arterial pressure were also recorded at the same times of VAS scores. The data were recorded by the anesthesiologist responsible for administration of spinal anesthesia and blinded to the group's assignment. Randomization. Patients were randomly allocated into 3 equal groups, 17 patients each. Group C, the control group, patients received intravenous fentanyl before spinal anesthesia. Group B, the pink block group, patients received pericapsular nerve group block before spinal anesthesia. Group F, fascia iliaca block, compartment block group, patients received fascia iliaca compartment block infrainguinal approach before spinal anesthesia. Techniques. Intravenous fentanyl. Patients in the control group received opioid analgesia, intravenous fentanyl in a dose of 1 microgram per kilogram before positioning the patient for spinal anesthesia. Pink block. Patients in group B received the pink block in the supine position under strict aseptic conditions After skin disinfection from the anterior superior iliac spine to the inguinal ligament, a low-frequency curvilinear ultrasound probe 25 MHz was placed transversely over the anterior inferior iliac spine. They rotated caudally about 45 degrees to align with the pubic ramus. Key anatomical structures identified are the femoral vessels, pectineus muscle, iliopsoas muscle and tendon, iliopectineal eminence, and pubic ramus. Here you can see a figure of the ultrasound view of pink block showing the femoral artery to the left and the vein, the psoas tendon in the middle of the screen, and the iliopectineal eminence below it. Then a 22 gauge 80 mm spinal needle was advanced in plane from lateral to medial, with the tip positioned in the plane between the psoas tendon anteriorly and the pubic ramus posteriorly, where the local anesthetic was injected. After negative aspiration, 20 ml mixture of 10 milliliters of bupivacaine 0.5% plus 2.5 milliliters, which is 250 milligrams of magnesium sulfate, completed with normal saline to a total volume of 20 milliliters, was injected in a 5 milliliter increments, which while observing for adequate fluid spread in. Here we can see a video of the ultrasound view of the pink block. Here is the anterior inferior iliac spine. Then we proceed with the probe medially. Here we can see the pectineus muscle and the iliopectineal eminence below it, and the femoral artery and the vein to the left of the screen. Rotating the probe caudally will show the iliopsoas tendon and the iliopectineal eminence. And here reticular Doppler and Doppler to confirm the femoral vessels. Fascia iliaca compartment block. Patients in group F received an infrainguinal fascia iliaca compartment block in the supine position under aseptic condition. After skin disinfection of the upper thigh, a high-frequency linear ultrasound probe from 10 to 15 MHz was placed at the inguinal crease to identify the femoral vessels in the short axis, then moved laterally to visualize the iliacus muscle, the overlying fascia iliaca, and the femoral nerve lateral to the femoral artery. Here in this figure, we can see the femoral nerve in the left upper part of the screen, marked by a yellow arrow. Then we can see a red arrow in the right part of the screen, marking the fascia iliaca and the space between it, the virtual space between it and the iliacus muscle, and the iliacus muscle below the fascia iliaca. A 22 gauge 80 mm needle was advanced in plane until penetration of fascia lata and fascia iliaca was filled. Correct needle placement was confirmed by a test injection lifting the fascia iliaca. After negative aspiration, 30 milliliters of local anesthetic mixture, 15 milliliter of bupivacaine 0.5% plus 2.5 milliliters of magnesium sulfate, which is 250 milligrams, completed with normal saline to a total volume of 30 milliliters, was injected incrementally under ultrasound guidance with visualization of an anechoic spread beneath the fascia iliaca, indicating appropriate distribution of the anesthetic. Here you can see a video of the ultrasound view of fascia iliaca. To the left of the screen, we can see the femoral artery pulsating. Then, right to it, the femoral nerve lying below the fascia iliaca, and the iliacus muscle to the left of the screen. For all patients in the three groups, after analgesic intervention, 5 minutes after intravenous fentanyl injection and at 30 minutes after regional blocks, Static VAS score was assessed. When static VAS score was less than or equal to 3, the leg raising test was done to assess the dynamic VAS. Patient was positioned to receive spinal anesthesia when dynamic VAS is less than or equal to 3. VAS score during positioning was also recorded. After 30 minutes in the block groups and 5 minutes in the intravenous fentanyl group, if VAS score higher than 3 during passive leg raising test, the analgesic intervention was considered failed to achieve the targeted level of analgesia, insufficient analgesia. In such cases, intravenous fentanyl 25 microgram was given every 5 minutes with maximum dose of 100 microgram till VAS score is less than or equal 3. These cases were recorded as a failure of the analgesic intervention. Administration of spinal anesthesia. Spinal anesthesia was administered in the sitting position by an anesthesiologist blinded to group allocation under strict aseptic conditions. After skin sterilization, local infiltration with lidocaine was performed, followed by a paramedian spinal puncture at the L3-L4 interspace using a 25-gauge Quincke needle. Correct intrathecal placement was confirmed by free cerebrospinal fluid. Then 2.5 milliliters, 12.5 milligrams of hyperbaric bupivacaine, 0.5% plus 0.5 milliliters, which is 25 micrograms of fentanyl was injected. The needle was then withdrawn, the site dressed, and the patient positioned the spine with supplemental oxygen via a face mask. Quality of spinal anesthesia procedure was evaluated using the following parameters: duration of spinal anesthesia procedure, time in minutes measured from starting patient positioning maneuver till spinal needle withdrawal, anesthesiologist and patient satisfaction. Sensory block was evaluated using BIM brick using hypodermic needle in the mid-axillary line. Motor block was evaluated using modified Bromage scale. The surgery was started after achieving grade 3 on modified Bromage scale and sensory level reaching umbilicus T10. Postoperative in the post-anesthesia care unit, all patients received standardized postoperative analgesia, 1 gram intravenous paracetamol every 8 hours and 15 milligram intravenous ketorolac every 6 hours. Postoperative pain was assessed using the static VAS, the predefined intervals up to 24 hours, and heart rate and mean arterial blood pressure were recorded concurrently. Rescue analgesia with nalbuphine 0.1 milligram per kilogram was administered if VAS exceeded 3 or pain became intolerable, and the time to first request and total rescue analgesic consumption during the first 24 hours were recorded. The duration of spinal anesthesia defined as the time from intrathecal local anesthetic injection to regression of sensory block to the S2 dermatome was recorded at the end of 24 hours. Postoperative patient satisfaction was evaluated using 1 to 3 patient satisfaction score. Data collection. Patient characteristics, age, sex, body mass index in kilogram per square meters, as a grade, and operative data, fracture type, fracture site type, and duration of surgery. VAS score was recorded at the following times: at baseline before analgesic intervention, static during rest, and dynamic during passive leg raising test. After analgesic intervention, 5 minutes after intravenous fentanyl, and 30 minutes after regional blocks, static and dynamic VAS scores. During patient positioning for spinal anesthesia, postoperative at time of arrival to post-anesthesia care unit, 0 hour, then at 1, 2, 4, 6, 12, 18, and 24 hours. Heart rate and mean arterial blood pressure at the same times of pause, duration of spinal anesthesia procedure, anesthesiologist and patient satisfaction during positioning for spinal anesthesia, duration of spinal anesthesia, time to first rescue analgesia, and the total amount of rescue analgesic consumption during the first 24 hours postoperative. Patient satisfaction for postoperative analgesia in the first 24 hours postoperative. Complications related to the block technique as hematoma or quadriceps motor weakness or side effects to the study drugs, for example, nausea, vomiting, or delirium. Results. There was no statistically significant difference among the three studied groups regarding patient characteristics, which is shown in Table 1. Table 2 shows the operative data among the studied groups. There was no statistically significant difference among the three groups regarding operative data, which is site and the type of the fracture or the type and the duration of the operation. Here in Table 3 is the preoperative visual analog score among the three groups. Regarding VAS in the preoperative period, at baseline, there was no significant difference in the pain scores among the three study groups, either during static, at rest, or dynamic with leg raising test. After analgesic intervention, the three groups demonstrated a significant reduction in VAS scores in both static and dynamic states compared to baseline, and no significant difference was observed among the groups in the static VAS score. In contrast, dynamic VAS scores were significantly lower in the Benga and the fascia iliaca compartmented block groups than in the control group, with no significant difference between the Benga and the fascia iliaca block group. During positioning for spinal anesthesia, both block groups, Group B and F, recorded lower VAS scores compared to the control group, Group C, while groups B and F remained comparable. Here in Table 4, we see the preoperative heart rate in beats per minute among the three groups. At baseline, heart rate was comparable among the three groups in both the static and the dynamic states. After analgesic intervention, all groups showed a significant reduction in heart rate, both static and dynamic states compared to baseline. No intergroup differences were observed in the static state, while a significant difference emerged during the dynamic state as the control group demonstrating higher heart rate than both the Benga and the fascia iliaca compartment block groups, with no significant difference between the two block groups. During the positioning for spinal anesthesia, heart rate showed a significant difference among the three groups. Both the Benga and fascia iliaca compartment block groups exhibited significantly lower heart rates compared to the control group, whereas no significant difference was observed between the Benga block and fascia iliaca compartment blocks. Regarding mean arterial pressure among the three groups, at baseline, mean arterial pressure was comparable among the three groups in both static and dynamic states. After analgesic intervention, mean arterial pressure decreased significantly in all groups compared with baseline in both conditions. No intergroup differences were observed in the static state, while significant difference was noted during dynamic state, with both the Benga block and fascia iliaca compartment block groups showed significantly lower mean arterial pressure than the control group, with no difference between the two block groups. During positioning for spinal anesthesia, mean arterial pressure differed significantly among the three groups. Both the Benga and fascia iliaca compartment block groups showed significantly lower mean arterial pressure compared to the control group, whereas no significant difference was found between the two regional block groups. Regarding quality of spinal anesthesia procedure among the study groups, the duration of spinal anesthesia procedure in minutes was significantly longer in the control group compared to both Benga block and fascia iliaca compartment block groups, with no significant difference between the two block groups. Anesthesiologist and patient satisfaction showed a statistically significant higher percentage of satisfaction in the Benga block and fascia iliaca compartment block groups compared to the control group, with no significant difference between the two block groups. Concerning the duration of spinal anesthesia, there was no significant difference among the three groups. Regarding VAS score in the post-operative period, post-operative VAS scores were initially comparable among the three groups at post-anesthesia care unit arrival 0 hour, with all patients reporting no pain. At 1 and 2 hours postoperatively, groups Benga and fascia iliaca showed significantly lower VAS scores than the control group, with no difference between the two block groups. From 4 to 18 hours postoperatively, significant differences persisted with the control group, showing the highest pain scores, the Bing group intermediate scores, and the Fasciolata group the lowest. By 24 hours postoperatively, both scores were similar with no significant differences observed. Regarding heart rate in the postoperative period, postoperative heart rates were initially comparable among the three groups at post-anesthesia care unit arrival, 0 hours. At 1 and 2 hours postoperatively, groups Bing and fascia iliaca had significantly lower heart rates than the control group, with no significant difference between the two block groups. From 4 to 18 hours postoperatively, heart rates differed significantly among all groups, with the control group showing the highest value, the Bing group intermediate, and the fascia iliaca group the lowest. By 24 hours postoperatively, heart rates were similar across all groups with no statistically significant differences. Regarding postoperative mean arterial pressure among the study groups, it was comparable among the three groups at post-anesthesia care unit arrival 0 hour. At 1 and 2 hours postoperatively, both the Bing block and fascia iliaca block groups had significantly lower mean arterial pressure than the control group with no significant difference between the two block groups. From 4 to 18 hours postoperatively, mean arterial pressure differed significantly among the all groups, with the highest values in the control group, intermediate in the Bing group, and the lowest in the fascia iliaca group. By 24 hours postoperatively, mean arterial pressure was similar across all groups, showing no significant differences. Regarding risk analgesia in the postoperative period, in this table shows the time to first rescue analgesia. The fascia iliaca compartment block group had the longest duration, 15.5 hours, followed by group Bing block 8 hours, and the control group recorded the shortest, 2 hours. Duration with no significant differences between the Bing and fascia iliaca groups. Total opioid consumption in the first 24 hours also showed significant differences, where the control group required the higher median dose, 34 milligrams, compared to 8.6 milligram in the Bing group and 7.2 milligrams in the fascia iliaca group. Post hoc analysis confirmed that both block groups consumed significantly less opioids than the control group, with no significant difference between the two block groups. Postoperative patient satisfaction differed significantly among the groups. In the fascia iliaca group, 64.7% of patients reported excellent satisfaction compared with 41.2% in the Bing group, while no patients in the control group reported excellent satisfaction. Satisfaction was significantly higher in both block groups compared with the control group, with no significant difference between the Bing block and fascia iliaca compartment block groups. Regarding postoperative side effects and complications, Group C showed significantly higher incidence of nausea, vomiting, and delirium compared to B and F, while Group F showed significantly higher incidence of the occurrence of quadriceps femoris muscle weakness. Ultrasound-guided pericapsular nerve group block. Ultrasound-guided pericapsular nerve group block is as efficient as fascia iliaca compartment block to provide effective analgesia to elderly patients with hip fractures during positioning for spinal anesthesia and in the postoperative period. Both regional block techniques provided superior analgesia compared with intravenous fentanyl and decreased the postoperative opioid consumption with its side effects. Patient satisfaction distribution was nearly equal in the two block groups, and both were significantly higher than intravenous fentanyl. However, Bing block has an advantage over fascia iliaca compartment block as it doesn't affect the quadriceps femoris muscle. Recommendation. Recommendations to enhance anesthetists' knowledge and experience in regional block techniques, such as Bing block and fascia iliaca compartment block, as safer and more effective alternatives to conventional opioid analgesia, particularly in high-risk patients with comorbidities such as elderly and obese. Incorporation of catheter placement with the regional block techniques to allow repeated administration of local anesthetics and/or adjuvant agents. thereby enhancing analgesic efficacy and prolonging the duration of pain relief. Double-blinded was not feasible in this study. A single bolus injection of local anesthetics was used in the two block groups and intravenous fentanyl in the control group prior to positioning. The difference in the volume and the dose of the injectate between the two block groups could be a main confounding factor in our results. VAS score was the principal method of evaluation of pain, which is subjective and can vary with the level of understanding between patient and anesthesiologist. Lack of objective means of assessment of block onset, time from local anesthetic injection to onset of the analgesic effect. Thank you.